Lung cancer screening. The aim of screening is to do a low dose CT scan to detect the cancer at its earliest stage and is increasing likelihood of the cure at early stage. And when doing this, there are several important considerations, including the safety, sensitivity, specificity, subsequent need for follow-up, and the frequency of this specific type of cancer, along with the severity and treatability. Although there are potential benefits of lung cancer screening on mortality have been shown in several studies, screening is underutilized and only 4% are eligible for the screening, actually being screened every year. Screening could be done by a chest X-ray, and which demonstrated a survival benefit as a screening modality despite multiple attempts with large trials. This finding is most important of these trials. In one of the projects, it was investigated the chest X-ray sputum cytology uh, were used to identify the cancers. In other trial, prostate, lung cancer, and colorectal cancer screening together, there was in this trial there is no difference between screened and unscreened subjects. So, low dose CT scan. The failure of the chest X-ray demonstrated survival benefit in the screened population led to exploration of other modalities, including low dose CT, and which is used in the National Lung Screen Trial. So in low dose CT scan, no IV dyes is used and is scan completed under a minute. So National Lung Cancer Screening Trial is a large multinational randomized clinical trial that investigated the screening facts of the low dose CT in high risk population. Non-smokers were included if they required to quit smoking more than 15 years prior to enrollment. Subjects are randomized in CT screening and screening by chest X-ray. That's a control group. The trial is scanned early, and the patient screened by CT scan were more likely to be diagnosed with stage 1 lung cancer and had a significantly lower rate of stage 4 disease. The number of subjects needed to screen to prevent lung cancer death is 320. The screening was without some risk, and a quarter of the patients with CT screening had a positive finding compared to 7% in chest X-ray group. False positive rate was high, greater than 90% of the group, while having the follow-up of positive screens was left to the individual discretion. Additional concerns have been raised regarding the generalizability. There was another trial from Netherlands with randomized low-dose CT scan cancer trial, and in the low-dose CT group, lung cancers were more likely to be diagnosed at an early stage, 59% in the stage 1. The most recent guidelines is annual low-dose CT screen for patients who have 30 pack year smoking history, no routine screening for low and intermediate risk patient. A minimum of 3 CT scans should be performed for screened patients. So disparities in lung cancer screening The screening has provided an opportunity for lung cancer at an early stage. The current screening guidelines may miss the underrepresented population and disproportionate lung cancer burden. The African American patients have higher lung cancer mortality than white patients. Future consideration, it remains to be seen whether other screening modalities will be integrated to screening recommendation, including FGD PET biomarker testing assessing the tumor growth pattern. Current technologies such as immunostaining and molecular analysis for sputum are being investigated for potentially a non-radiographic method to contribute early detection of lung cancer. Integrating the patient-centered social media such as hashtag lung cancer social media, LCSCM, and other patient activation strategies to expand lung cancer awareness and screening will also be important. It is also crucial to re-examine and re-evaluate recommendations periodically and revise them as an appropriate based on new research data. As for this writing, and this USP SFT is recommending revising the lung cancer screening guidelines to expand the recommendation age to 50 to 80 years of age and lowering the number of PAC years history to 20, and this will increase the mortality benefits, life years gain, and the number of eligible individuals for lung cancer screening to decrease the disparities between the screening and eligibility, especially for women who are often light smokers. African American patients would also benefit from these changes, and they are often light smokers and may have high dose within the low pack years because of targeted tobacco products. Screening should also be eventually be personalized for each patient. Thank you.